Baylor University Medical Center is the third largest church-affiliated hospital in the United States. Licensed for 1,455 beds, Baylor is regarded as one of the country's foremost tertiary medical centers and the market leader in Dallas, a city known for its leadership in medical science and health care. Internationally, Baylor is known for its excellence in transplantation and the treatment of digestive diseases and cancer. The center also is renowned for treating heart and metabolic diseases, and Baylor is quickly becoming a leader in the area of sports medicine. Baylor is dedicated to providing quality patient care. It is a major research and medical education center for Dallas and the southwestern United States. As part of Baylor's commitment to medical education, the center provides Grand Rounds, a forum for presentations on the latest advances in medicine and surgery. We are pleased to share this presentation with you.
Well, this is a coronary artery, and if you look at that person next to you, one of you is going to die from atherosclerotic disease. Now, I know it's the other one, not you, but this is the problem facing the Western world. There's just no doubt about that, is that half of us, or nearly half of us, 45% of us, will cross the river because our arteries get filled up with these atherosclerotic plaques. Now, the problem with atherosclerosis is it's not an isolated situation. There's not a plaque just in one artery or in one portion of one artery. Unfortunately, it covers most of the surfaces of the interior linings of the arteries. Now, to make that point, let me show this slide. This happens to be from a group of patients who died suddenly outside the hospital. The typical person is the one who is a man who's watching television, let's say, and suddenly has cardiac arrest. Now, one of the things we've done through the years in my lab is to take these major coronary arteries off the heart and divide them into little bitty 5-millimeter segments, and then ask how many of these little 5-millimeter segments are narrowed to these categories of narrowing. And the answer there is about a third of these little bitty segments in the typical patient with fatal coronary disease or cardiac arrest outside the hospital have a narrowing of greater than 75% in cross-sectional area. Another third have narrowing 51 to 75%, and a very small percent have segments that are virtually normal. So it's a very extensive, diffuse process. Now, this busy slide here is an attempt to show how much narrowing is present in these other subsets in addition to the sudden death group. Now, this was a sudden death group, the top one here. About 36% of the lengths of the arteries are severely narrowed. Acute myocardial infarction, very different clinically, of course, but the same degree of narrowing by plaque. Healed myocardial infarction, a bit less. This is an unstable angina group here. Unstable angina patients have the worst coronary narrowing of all. About a half of the coronary tree is severely narrowed in patients, at least with fatal unstable angina. This is a montage in a patient with unstable angina, again to show the diffuse nature of the process. Each one of these histology sections here represents a cross-section of a 5-millimeter segment. If you go down the right coronary artery, try to find one of these segments that is devoid of a plaque, and it's very difficult. This is left main, terribly narrowed in this patient, left anterior descending, very narrowed. Now, if you're going to blow up a balloon in this left anterior descending, where are you going to blow it up? Here, 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 here. It's in most places, all the way out to right there, actually. Left circumflex in this patient, the dominant artery, terribly narrowed all the way out. Now, that's what you as a healthcare person, that's what the patient is up against with atherosclerotic coronary disease. Now, I realize that most of you do not look at 5 mm sections throughout the day, but many of you look or interpret coronary angiograms. This slide is an attempt to show how much narrowing is present in the 4 major arteries and how much narrowing is present in the average 5 mm segment in patients with 1, 2, 3, or 4 vessel disease by angiogram. Here in the average patient with 1 vessel disease, what that really means is that the artery which is severely narrowed by angiogram simply has the greatest quantity of plaque, but other arteries, of course, also have plaque within them, just a little less. In the average 5 mm segment, and there are about 50 per patient, in the usual patient or the average patient with 1 vessel disease, about 40% of the lumen is obliterated by plaque. In the average person with 2 vessel disease, it means the quantity of plaque is greater, and one is dealing here with a 50-50 situation. About 50% of the lumen has been occupied by plaque. The average person with 3 vessel disease, angiographically, the quantity is even greater. Now one is living on 40% of the lumen on the average. And the average patient with 4 vessel disease, and most of these patients are unstable angina patients, the quantity of plaque is really enormous, such that one is living on 30% of the lumen on the average. One of the things about coronary disease, I think some people think, well, this is an old person's disease. Not so. The average age of death in patients with coronary disease in men who do not have angioplasty or bypass is 60, age 60. The average age of death in women from coronary disease on a natural history basis is 68. What this slide shows is these are patients, about 900 patients who were studied at necropsy. They never had angioplasty, never had bypass. And the men here are in hatched things. Most of the patients with fatal coronary disease under 70 are men. It takes to the 9th decade here until women pass the men. I think most of the men are dead. That's the reason there are not many men left there. The expert panel on, adult panel on lipids in 1988 picked out 10 atherosclerotic risk factors. And we're all familiar with these. My own view is that there's just one direct atherosclerotic risk factor, and that's an elevated cholesterol level. We all probably have different definitions of what is elevated, but all the other risk factors, in my view, are indirect. Now, what I mean by that, if one has systemic hypertension or if one smokes many packs of cigarettes a day, and if that total cholesterol level is under 150 or 140, there's no evidence that these factors produce atherosclerotic plaque. On the other hand, if the total cholesterol level is over 150, these other factors are quite additive. So I'm going to spend most of the rest of the time on the cholesterol problem. Now, this slide comes from the Lipid Research Clinic, and it shows the frequency or the percent of our population age 20 to 74, sorry about that, with total cholesterol levels greater than 240 milligrams per deciliter. This is really a shocking slide, at least to me. After age 50 or so, about half the women in this country have total cholesterol levels greater than 240. The total cholesterol levels after age 60 in men are lower, but those with the very high levels, I'm afraid, are no longer living. And that's one of the reasons I think that the men are less represented here. The point there is that elevated total cholesterol levels is a bottomless pit in this country. Now, these are the factors that show beyond any reasonable doubt, in my view, that cholesterol is linked to atherosclerotic plaques. This is not a controversial issue anymore. The facts are in as far as I'm concerned. It started about 1908 by some Russian physiologists who fed high cholesterol diets to certain non-human animals, and the animals they chose were rabbits. It's very important that herbivores be studied if one is trying to produce atherosclerosis. It's impossible to produce atherosclerosis in a carnivore. That should say something to us, I think. But they produced these plaques in these rabbits, and the plaques were similar to those occurring in humans. The second thing that happened was the biochemist found cholesterol within these plaques. And then not much happened until after World War II, when the international epidemiologic studies got going. And I conclude from those studies this statement: atherosclerotic plaques large enough to produce clinical problems occur only in persons having serum or plasma total cholesterol levels greater than 150 milligrams per deciliter. When we're born, our umbilical blood apparently has a total cholesterol level of about 75 milligrams per deciliter. Within 2 weeks of life, it shoots up to about 150, and then it stays on an average of about 150 until we graduate from high school, and then it gradually goes up after that. If we could keep our total cholesterol level what it was when we graduated from high school, I think our health would skyrocket. Pure vegetarians, incidentally, have total cholesterol levels averaging 140. Items 4, 5, and 6 were solidified this last decade. The higher the blood total cholesterol level, the greater the chance of having symptomatic atherosclerotic disease, the greater the chance of dying from atherosclerotic disease, and the greater the extent of the atherosclerotic plaques. Number 5 came in 1984, confirmed in 1987. Lowering the blood total cholesterol level decreases the chances of fatal or non-fatal atherosclerotic disease. And number 6, most of the studies were in 1990. Atherosclerotic plaques at least have the potential to regress when high blood cholesterol levels are lowered. So in my view, the evidence is in. It would hold up in any court in any land. Now, this is Ansel Keys' famous 7-nation study. He and his colleagues went to these 7 nations, studied approximately 13,000 people, found that people residing in certain acreages on the planet had a very low frequency of symptomatic coronary artery disease. Those in other countries like USA, Finland, a very high frequency. What he found was in southern Japan, the average total cholesterol, and most of this data was collected in the early 1960s, was approximately 150. In eastern Finland, it was approaching 300. Dr. Keys concluded that atherosclerosis was primarily a cholesterol problem. This is a slide from Stamler's group in Chicago, the Mr. Fitz study. This is a very impressive study in my view because of the number of people screened, over 350,000 individuals. These were all men, sorry ladies, aged 35 to 57. They were all asymptomatic when they entered the study. They were divided into 10 groups according to their serum total cholesterol level. And what this study shows so nicely is as that level goes up, and up, the coronary artery mortality, and that's a 6-year mortality, goes up, and up. No study shows it better, in my view, that total cholesterol level is a quantity. The higher that quantity, the greater the risk. Now, the National Heart, Lung, and Blood Institute, where I am, used this study to suggest that all Americans should attempt to get their total cholesterol levels under 200. And the reason for that is this. If you look from 153 to 198 here, and then go over to the 6-year death rate, it really doesn't change a great deal between 153 and 198. Only 1 person per 100, 3.2 to 4.2 per 100. But after 198, it rapidly shoots up. And that is an achievable goal. This is a study from Oslo, Norway. What these investigators did was study coronary arteries at necropsy, and they found that the higher the total cholesterol level, the greater the plaque in the coronary arteries. Similar studies have been done in aorta. This busy slide here shows the two studies which have shown beyond a reasonable doubt that if groups of people lower their total cholesterol levels, that the frequency of heart attack does indeed drop. The one on the left here is a lipid research clinic study, 1984. The one on the right is a Helsinki heart study. They were both very similar. Two important conclusions from these studies, in my view. Number one, they both show the same thing. And that is, if groups of people lower their total cholesterol level, here by a drug, cholestyramine, here gemfibrozil, after a certain period of time, here 7 years, here 5 years, that the group of people allocated to the drug arm of the study have a lower frequency of heart attack compared to those not put on the drug study. The other important item, in my view, about these two studies is that these reductions, 19% and 34%, are very conservative estimates. And the reason I say that is because both of these studies were analyzed by the intention to treat method. And what that means is that about 30% of the people in each study quit taking the drug within 1 year. And despite that, they stayed in the drug arm throughout the entire study. If one looks in this study, for example, at the people who actually took the drug in the amount allocated for 7 years, there was an average of 25% reduction in total cholesterol and a 50% reduction, not a 19%, but a 50% reduction in heart attack during that 7-year period. And today there are several drugs that readily reduce our total cholesterol levels more than that. Now this slide is an attempt to briefly mention the secondary prevention trials. Now these are trials, of course, in people who have already had an atherosclerotic event, and then they're either put on a drug or have a partial ileal bypass operation, or they're put on an extremely stringent diet. Now, of these 6 studies, 5 were published in 1990 and 1 in 1992. So this is relatively recent data. All but this group of patients had a previous coronary event. These people had angiographically demonstrated coronary narrowing. All of these are angiographic studies. They had an angiogram at baseline, and then several months later, 48 months, 24 months, 120 months, etc. The point of all of these studies is that whatever drug was used, or diet or whatever, that there was evidence of regression of atherosclerotic plaques, and more importantly, probably, there was a higher frequency of lack of progression in the group treated with the drug compared to those not treated. Now this is a typical slide. This is from Blankenhorn's study, and these were in patients who had already had a bypass operation, 2 years, 4 years. Now, if you take any group of people who've had a bypass operation, or indeed have had a coronary event, within a 2-year period or within a 4-year period, one would expect to have more coronary narrowing than at baseline. But what they found in this study, and these patients were treated with clostopol and nicotinic acid, very high doses actually, the 0 means no progression over a 4-year period. And that was much higher in the drug arm than the other arm. The minuses means that plaques shrunk, got smaller, and for practical purposes, that was only in the group treated with the drug. Now, if I had a bypass operation, I guarantee you I'd be on a lipid-lowering drug from that point on. If I had angioplasty, I would be on a lipid-lowering drug from that time on. The evidence is in. This is a study, this is Greg Brown's study, another secondary prevention trial. These patients also had had a previous coronary event. This is a splendid study because the angiograms were analyzed by quantitative means. Control group, lovastatin plus cholesterol, niacin plus cholesterol. Look at the tremendous reductions in LDL, increases in HDL. Cardiovascular events, much smaller in the group treated with the drug. This is a 2.5-year study. And this is the angiographic data, evidence of regression in the groups treated with the drug, very low in those not treated with the drug. If I had any atherosclerotic event, angina, myocardial infarction, which healed, carotid disease, peripheral arterial disease, I would be on a lipid-lowering drug from that point on. Now, this is a Bookwall's study. These patients also had a bypass, but this was a partial ileal bypass. And all of these individuals had had a myocardial infarction in the past. Now, I'm not pushing partial ileal bypass as a means of lowering total and LDL cholesterol level, but it certainly works. These people had a reduction. Her first edition came out in 1971. But I think we, as physicians and professionals in the medical community, have got to become sensitized to what we are doing to this planet because of what we are putting in our mouth every day. Look at this just on cows. The planet contains 1.3 billion cows and 5.3 billion people. 25% of the Earth's land mass is used for pasture for cattle. The U.S. population, U.S. is populated by 100 million cows, 250 million people. 100,000 cows are slaughtered every 24 hours. The U.S. ranks first among the beef-producing nations of the world, 22% of the global output, and we consume 23% of the beef produced on the planet, and we wonder why we have so much atherosclerosis. Is it really such a big mystery? The average American consumes 65 pounds of beef every year, and the meat of 7 1,100-pound steers in her or his lifetime. Americans consume the most beef each year, followed by Australians, etc. And what happens? We gain too much weight. This is a slide I took from the Harvard School of Public Health. It has to do with body weight and when we die. They call it mortality ratio. And what this shows, whether you're a man or whether you're a woman, the more we weigh, the sooner we die. Now, there are these exceptions like Winston Churchill, but in groups of people, the more we weigh, the sooner we die. This is a slide it took World War II to produce, World War II, 1939 to 1944, and as you know, during that period of time, there was not much red meat available in certain countries, and not much milk, and not much cheese, and not much butter. And what happened to the cardiovascular death rate? Well, in Sweden, boom, it fell. In Finland, boom, it fell. In Norway, boom, it fell. In the USA, it just kept on going up. Can we change our health? Of course we can. This is a slide I took from the JMA. It has to do with cancer of the breast. What is shown here in the horizontal axis is the amount of fat consumed by adults on an average in countries listed here. And on the vertical axis is the death rate from cancer of the breast. Now here's the USA right here. We eat on an average over 140 grams of fat every day. And we have one of the highest death rates from cancer of the breast in the world. Those nations that eat, individuals in nations that eat relatively little fat have a very low frequency. Now the point of this slide, this happens to be cancer of the breast. It could just as easily be cancer of the colon. And of course, it could just as easily be systemic hypertension. And of course, it could just as easily be atherosclerosis. The less fat any society eats, the lower the frequency of these 4 major diseases. Now, the American Heart Association recommends that we lower our percent of calories from fat from about 40% down here to 30%. The Japanese historically have been down here at 10%. The Japanese are now up to 23% on the average. I think that we in the USA should shoot for this 20%. Now that's difficult. It's very difficult. But if we did, our health would skyrocket. Now, I'm very fond of these lipid-lowering drugs. As I understand it, about 2 million Americans are now on one or more lipid-lowering drugs. Worldwide, I understand about 3 million people are on lipid-lowering drugs. And yet, in this country alone, after age 55 or so, half of the women in this country have total cholesterol levels greater than 240, and about 40% or so of the men. I think these drugs should be used far more than they are presently. And in people who have had atherosclerotic events, almost certainly the way to go is combination therapy, because combination of an HMG-CoA reductase, for example, and a bile acid resin will lower one's total cholesterol by 50%, and LDL approximately the same. Some people say, well, these drugs are toxic. Well, the Excel study with lovastatin, for example, shows that with one tablet, 120 milligram a tablet a day, there are no more side effects than with placebo. As the dose goes up, the amount of side effects increase. But compared to the toxicity of atherosclerosis, these drugs are relatively non-toxic. Look at the combination. This is from a paper this month in the American Journal of Medicine by Peter Jones from Houston. The combination of these drugs, look how they can lower LDL cholesterol. 50%, 50%, 70%, 56%. When I have a heart attack, I'm going to be on combination right away. This is my own view. This is not the general medical view, but this is my view. Simultaneous initiation of low-fat, low-cholesterol diet plus lipid-lowering drug therapy beginning immediately after the first atherosclerotic event, irrespective of the initial total LDL and HDL cholesterol levels, because in my view, whatever the levels are in that particular patient, they are too high. This is the status of systemic hypertension in this country in 1972. In 1972, for every 100 people who had systemic hypertension, only 60 knew they had it. The other 40 were unaware that they had it. Of the 60 who had it, 30 were not seeing a physician. 30 were seeing a physician, and of those 30 seeing a physician, only 15 had the hypertension adequately controlled, which means in 1972 in this country, 15 out of every 100 people with systemic hypertension were having the blood pressure controlled. Today, that figure is up to 50%, and the frequency of stroke has dropped enormously. Now, with hypercholesterolemia, with lipids, we are far worse off today than hypertension was in 1972. We haven't even started in this country on lipids. I show this, I think Dr. Free here will like this. This is from 3 anthropologists. This was a study published in American Journal of Medicine about 3 years ago. These Melvin Connor and Marjorie Shostak are very prominent anthropologists, and they asked the question, what did our Stone Age ancestors eat? And is that information applicable to us today? Now, what they actually did was go to Africa and study the bush people. And they believed the bush people, at least when they studied them, lived and ate just like our Paleolithic ancestors many thousands of years ago. And these are some of their conclusions. Many diseases in the late 20th century USA were uncommon, rare, or non-existent among our Stone Age ancestors. Fact 1. Our genes have not changed since anatomically modern humans became widespread about 35,000 years ago, or from a genetic standpoint, current humans are still late Paleolithic, pre-agricultural hunter-gatherers. In contrast to our genes, of course, our culture has changed enormously, beginning with the agricultural revolution about 5,000 years ago and accelerating since the Industrial Revolution about 250 years ago. In other words, we have Stone Age bodies in an atomic age. Our remote ancestors had little or no exposure to either tobacco or alcohol. Their lives required both aerobic and resistance exercise, and their nutrition was derived almost exclusively from wild game, not fattened game, wild game, and uncultivated vegetable foods. Obesity, diabetes, hypertension, atherosclerosis, and the most frequent cancers are diseases resulting from our current genetic lifestyle mismatch. The present societies who do not develop atherosclerosis, they're getting to be fewer every decade, live like our Paleolithic ancestors. They have low blood cholesterol levels, no hypertension, do plenty of physical exertion, do not use tobacco, and their diets are low in total fat and have more polyunsaturated fatty acids than saturated fatty acids. Their blood is even thinner than ours. Now, these slides are coronary arteries at sites of maximal narrowing of 5 coronary arteries in a woman who was 103 years of age. Now, look at this left main here, just beautiful. I'll trade with her right now. This is a left anterior descending, beautiful. That's the biggest plaque she had in her body there in the right coronary artery. The reason I show this is to point out that we don't have to get atherosclerosis just because we get older. Atherosclerosis is not a degenerative disease. We are the degenerates, I'm afraid, not the disease. I think Mark Twain hit it pretty well. He said the only way to keep healthy is to eat what you don't want, drink what you don't like, and do what you'd rather not. So, folks, it's up to us. Thank you very much. Yeah, I'm sorry you asked that question. I really I understand that someone in your audience is working on that, but I don't quite understand it. There's no question that the French eat a lot less meat than we do, a lot less flesh. Some of their sauces, of course, are rich in fats, but I suspect their total calories is quite less than ours, and what their calories contain are different. Yeah, that's important.
Might repeat what you said.
Dr. Free said their cattle are not grain-fed. They're pastured cattle, and they don't develop nearly as much fat between the muscle as ours in this country.
Any other questions? Yes, sir.
Well, I think there are many reasons for exercising, and it's obviously good. I think that if one goes out and runs 5 miles and then stops by McDonald's on the way home, that it neutralizes the good effect of exercise. Now, I think it's, personally, I think it's more advantageous to be a non-exercising vegetarian than an exercising meat eater. Personally, I think that if you're 10 pounds over ideal body weight and you exercise, I think that's good, but I think it's better to be ideal body weight and not worry so much about exercise. The problem with exercise makes one feel better, makes one sleep better, makes the GI tract work better. It keeps the blood flowing better. And it is a mechanism to diminish calories in a way. I remember I was on the airplane a while back, and I was talking to this lady, and she was telling me about all the exercise she did. I was almost getting tired from listening to her. And then the lunch came, and I noticed that she didn't eat her pie. And I said, well, why don't you eat your pie? And she said, that's 400 calories. No, she said, that's 4 miles. That's 4 miles. Now, she knows how much work 4 miles is. And I think that's one of the things exercisers learn, that it's not easy to go out there and run 20 miles and so on. So it's better to eliminate the pie sometimes.
I think we had time for one more question.
The who? Yeah. Well,
I think it's boredom, isn't it? Boredom?
yeah, the question of what do people people in low fat societies, what do they die from? Well, number one is trauma. Trauma is very big in those societies. Trauma from automobiles, trauma from falling out of coconut trees, infection. The death rate is very high. But infection is a major problem.
Arthur?
Given the accuracy of facts, certainly most of us I think have said, and also given the profit margin for dispensing saturated fat, do you have any proposals for converting an evolutionary change, which might take 100 years as far as I'm concerned, to a revolutionary change, to decrease our intake of saturated fat, decrease slaughter of animals? How would you propose to do that?
I would propose that you go home tonight and not eat flesh. And when you invite people to your house, don't cook barbecue out in the backyard. I think physicians and healthcare people must set the example. And when we diminish the amount of flesh that we take in, it will spread. That's my view. I think it's an individual thing. Every time we don't eat meat, we are making a statement. Starts with each of us. And my own view is that the American Heart Association says that we should gradually change our diet. I don't agree with that. I think diet should be looked at, or eating should be looked at just like cigarette smoking. If you want to change what you eat, if you want to improve your health, just go home and do it. And do it, and change. I read, when I read Mary Moore LePay's book, I was absolutely flabbergasted. I didn't know all this was going on. I changed overnight. Boom. I just quit eating all that flesh.
This has been a presentation of Baylor University Medical Center in Dallas. For more information, contact the International Affairs Office, Baylor University Medical Center, 3500 Gaston Avenue, Dallas, Texas, 75246. Or call 214-820-6026. Our fax number is 214-820-7891.